Bismillahirrahmanirrahim. Question number 55. A 35-year-old dressmaker sustained a puncture wound from a sewing needle in the proximal interphalangeal flexor crease of her left index finger. Subsequently, the finger becomes swollen along its entire length. Passive extension of the digit elicited a severe pain. Which one of the following most likely diagnosis? So, a 35-year-old dressmaker sustained a puncture wound from a sewing needle in the proximal interphalangeal flexor crease of her left index finger. Subsequently, the finger becomes swollen along its entire length. Passive extension of the digit elicited a severe pain. Which one of the following the most likely diagnosis? So options are abscess of the mid-palmar space, superficial cellulitis, osteomyelitis of the proximal phalanx, collar stud abscess, Flexor Tenosynovitis. The clinical feature, particularly severe pain and passive finger extension, are classical of flexor tendon sheath tenosynovitis. The proximal interphalangeal flexor crease of the finger is precisely over the proximal interphalangeal joint line as illustrated here. So here is we can see the flexor tendon sheath of the palms and fingers relation to the bones and crease lines. Facial spaces of hand and rear extensions, the thenar eminence, thenar space, mid-palmar space, and forearm space. So this is flexor tendon sheath tenosynovitis. So the proximal interphalangeal flexor crease of the finger is precisely over the proximal interphalangeal joint line as illustrated here. The skin crease is at the site of binding of the deeper layer of the skin to the underlying flexor tendon sheath. Puncture wounds at this site are particularly prone to involve the underlying sheath and to introduce infection, usually staphylococcal and streptococcal infections. So this is the flexor tendon sheath tenosynovitis. The mid-palmar space is a potential facial space in the palm beyond the flexor tendon sheath to middle ring and little fingers and is not relevant to this situation. Cellulitis in the infection is the infection of the subcutaneous fatty soft tissues. The important diagnosis here is not a cellulitis but as a specific tendon sheath infection. Osteomyelitis of the proximal phalanx would need to have a spread from primary infection, suppurative arthritis of the interphalangeal joint, with more focal signs of the sepsis over the joint and the bone. Collar stud abscess in the finger refers to a variant of subcutaneous finger pulp infection in which a relatively small superficial abscess in the dermis communicates with a much larger abscess in the subdermal distal finger pulp. Resolution is delayed if the deeper abscess is not recognized and also drained. So this is the flexor tendon sheath tenosynovitis. Next question, a 55-year-old woman present with increasing dyspnea over 3 months period. Increasing dyspnea over a 3 months period. Examination finding include a raised JVP without displacement of apex beat. Which one of the following is the least likely to cause this combination of physical findings? So 3 months history of dyspnea, raised JVP on examination without displacement of apex beat. Least likely cause of this combination of physical findings: mitral regurgitation, carpal boneal, myocardial infarction, mitral stenosis, constructive pericarditis. So in this scenario, address the potential cause of raised JVP in the absence of cardiomegaly as reflected in non-displacement of the cardiac apex beat. So the mitral regurgitation is the only one of the five options which with disease progression invariably causes cardiac dilatation. Cardiac dilatation occurs well in the advance of secondary pulmonary hypertension and development of a raised JVP. The JVP can be elevated without cardiomegaly in each of the other options. Elevation of the JVP is one of the cardinal signs to look for in the cardiovascular examination. The height of a pulsatile internal jugular vein is a measure of central venous pressure. When a subject is sitting at 45 degrees, the JVP is normally less than 3 centimeters above the angle of the sternum and thus is not visible above the clavicle. The JVP can be visualized by positioning the subject in a more supine position and also by increasing the transmitted venous pressure by pressing over the right hypochondrium and the liver. In a dehydrated volume depleted patient, the JVP may not be seen even in the supine position. A raised JVP with or without cardiac dilatation is seen in conditions such as congestive heart failure, for example, due to ischemic heart disease, right heart failure, for example, called pulmonary right ventricular myocardial infarction, overload, volume overload, such as in renal failure, mitral stenosis, pericardial constriction, and effusion. A physiological state in which the JVP can be seen in the pregnancy, reflecting volume expansion, or raised non-pulsatile JVP is a manifestation of superior vena cava obstruction. The JVP usually seen rather than felt. The pulsation is abolished by gentle compression at the root of the neck with the transverse application of a finger across the medial sternocleidomastoid. In the setting of severe tricuspid incompetence, the JVP may even be palpable and it requires more pressure to abolish the pulsation. The JVP normally has a two characteristics peaks. The A wave corresponding to atrial contraction and a smaller V wave corresponding to right ventricular contraction. The carotid pulse may not transmit a C wave, but this wave is less easily identified at the bedside. There are two descent that are described X and Y. These are more difficult to appreciate than the peaks. So this is the JVP. X and Y are descent. So the correct answer is the mitral regurgitation. So the correct answer is the mitral regurgitation in which JVP would be raised without the displacement of the apex beat.